Welcome to the other one of the webinar series from SEEDS. And today we are very lucky that we have two speakers coming, but unfortunately one of our speakers is still not able to reach our webinar. So we will have a little bit change in the schedule. So we will start with what is supposed to be the second topic, palliative management of stage 4 lung cancer, and which will be given by Dr. Adli Azam Mohamad Razi. And Dr. Adli is, I think most of us know him very well. He's working for the University Technology Mara, and he's one of the leading thoracic surgeon in Malaysia. And today he's going to give a talk on the management of the stage 4 lung cancer. Please welcome to Ali.
Thanks, Poon. Hello, everybody. Good night. I'm supposed to be a second speaker, but it's all right. My topic going to be palliative management in stage 4 lung cancer. I think in managing stage 4 lung cancer, the principle that we need to understand that the aim is to provide quality of life to the patient. It involves multidisciplinary people in the team, including surgeon, oncologist, radiologist, palliative physician, and other specialists like pathologists and pulmonologists. The National Consensus Project for Quality Palliative Care, the CPG in 2013, they outlined the 8 domains of care as a fundamental components of palliative care. We as a physician or surgeon looking at physical aspect of care, which is in intensive symptom. But when we're talking about palliative care, it involves lots of other components, including structure and process of care, physiological, social aspect of care, spiritual, cultural, and of life care, and also ethical and legal aspect of care. Palliative symptom management in lung cancer mainly involve in general clinical problem due to primary tumors. It can be from metastasis, the treatment itself, and also paraneoplastic syndrome. And we have to not forget about other comorbid which the patient may have. Either it's tobacco-related or non-related disease. For example, cerebrovascular disease, coronary vascular disease like heart failure, peripheral vascular disease, and also COPD. And the age patient with a lung cancer is average is 70 years old. But we see younger patients in our population in Southeast Asia. But bear in mind, a great majority of lung cancer patients die of the cancer rather than the comorbid even at the early stage. This is a diagram that I took from Annal of Palliative Medicine. Show the symptom of everyone non-small cell lung cancer. It can be a thoracic pain, dyspnea, cough, that increase symptom burden to the patient. It increase anxiety, depression, and of course subsequently decrease quality of life. This due to possibly from airway compression, chest wall, or bone nerve invasion, pleural or pericardial effusion, pneumonia, or even treatment side effect. And various management options we can offer to the patient, either symptomatic medication management, palliative systemic anti-cancer therapy like chemotherapy, external beam radiotherapy, endobronchial intervention, and also complementary technique. The aim is to improve symptom control to the patient and also decrease anxiety and depression to the patient and subsequently improve quality of life. This table shows the causes of pain in patients with advanced and metastatic non-small lung cancer. It can be due to a thoracic lung tumor, maybe from distant metastatic tumor, and even the treatment itself. If a local tumor can cause compression, invasion to the airway, the chest wall invasion, the chronic inflammatory changes that occur around that, and many more. For example, distant metastatic tumor from the brain, from the bone, spinal cord, and also visceral metastasis. The treatment itself from chemotherapy that can cause cardiomyopathy, the radiation itself can cause chest wall syndrome, esophagitis, the surgery can cause infection, also incisional pain. When dealing with advanced lung cancer, the common clinical situation and mostly presented to us, namely pleural effusion, pericardial effusion, airway obstruction, and also hemoptysis. Malignant pleural effusion is among the common presentation, common in lung cancer. Second is breast, up to 15% in cancer patient. And when patient presented with a malignant pleural effusion, the median survival reported as 3 to 12 months. In management-wise, it mainly palliative. The ideal therapy for malignant pleural effusion is to have a complete fluid control to the patient, to improve the symptoms, to provide a good quality of life to the patient. And of course, the intervention have to be minimal invasive, as minimal as possible. And they aim to reduce hospital stay to the patient. And the two prime modes of therapy in this type of patient, the first one is incision indwelling catheter. And secondly, the creation of PLEURODESIS. When we talk about indwelling pleural catheter, it's a device that we insert into a pleural space. It's a tunnel under the skin with a small caliber, around 15 French, because it's allowed to stay in place for a prolonged period of times. Long-term IPC may lead to spontaneous PLEURODESIS and even reported up to 40 to 58% of patients. There's lots of trial talking about and discussing about how indwelling pleural catheter versus PLEURODESIS. And the cumulative evidence proposed that potential advantage of IPCs over top PLEURODESIS. Firstly, PLEURODESIS is only useful in patients with fully expanded lung after fluid evacuation. However, in non-expanded lung, which is trapped lung, it's not suitable. Secondly, the PLEURODESIS failure progressively increased with prolonged survival. By 6 months, top PLEURODESIS had failed in approximately half of the patient, and 32% of patients required pleural intervention. Thirdly, the top PLEURODESIS require hospitalization up to 4 to 5 days. And fourth, PLEURODESIS is known to provoke intense pleural and systemic inflammation with median rise of CRP up to 360% from baseline. So this can cause pain, fever, and some report of hypoxemia and also acute respiratory failure. Is there any difference between top PLEURODESIS and versus PIC? In Times trial, they're looking at effect on IPC versus chest tube and top PLEURODESIS for relieving dyspnea in patients with MPE. There was no significant difference between IPC and top PLEURODESIS at relieving a dyspnea reported in patient with no previous PLEURODESIS. In AMPLE, they are looking at the effect of IPC versus top PLEURODESIS on hospitalization day. However, although the IPC have fewer hospitalization from treatment to death, however, the magnitude of the difference is not uncertain of clinical importance. Although IPC show advantage to the patient with advanced lung cancer in managing malignant pleural effusion, it's not without complication. There's a reported of IPC-related pleural infection. It can be local to systemic. The report of catheter tract metastasis up to 10%, although 90% of them are mesothelioma. There's a symptomatic loculation. There's a fracture of catheter on removal. There's 3 to 9% of catheter blockage. The cause will be a problem for certain patient, and also the pain. PLEURODESIS is a procedure to obliterate the pleural space by fusion, the visceral and parietal pleura with fibrosis tissue. Ideally, the agent should be easily administered. It's safe. It has to be inexpensive and widely available. Considered for patients who are not on tunnel catheter or on systemic chemotherapy and not on patient is not a chylothorax effusion. There are numbers of skeletal agents that we can offer to the patient, namely TALC, either porridge or slurry, antibiotic like tetracycline, anti-neoplastic drug like bleomycin, and even autologous blast. Others are listed from the slide. In network analysis Cochrane database, they're looking at intervention for the management of MPE or malignant pleural effusion. It showed that top porridge is more effective PLEURODESIS in MPE than other frequently used method. However, no evidence suggests large difference between highly effective method with others. Their study, numbers of them, show there is no difference between porridge or slurry in using a top PLEURODESIS in terms of time to recurrent back to malignant pleural effusion. This is one of the guideline. We have numbers of guideline that we can refer to. This is one of them, which published by American Thoracic Society, looking at how we can manage a blind and pleural effusion. I just show you one of the flow chart or the algorithm, which, for example, this one asymptomatic patient, there is no need of a pleural intervention unless for diagnosis. In patient with after the drainage of fluid, the lung is expanded, then consider for top PLEURODESIS. Unless it's failed PLEURODESIS, we can consider IPC. In the patient which we put a chest tube, we managed to evacuate the fluid. However, the lung is not expand. Actually, it's a predicted very short survival. And this group of patients, we should consider to palliate properly by repeat thoracocentesis, morphine for pain, and oxygen supplement. If this patient predicted with a better survival, we can consider IPC or TALC PLEURODESIS. Pericardial effusion is another presentation that troublesome to us, presented to us with patient with lung CA. Dyspnea is the most common presentation to this group of patients. They can present with pleuritic chest discomfort, cough, fatigue, hoarseness because of recurrent laryngeal nerve involvement. They can have hiccup with phrenic nerve involvement and also syncopal. But this is evidence of a tamponade. In terms of clinical sign, it's very poor sensitive to look and suggest that the patient have a pleural effusion. Most of the time, it's just a tachycardic. If patient presented with back triad, with hypotension, muffled heart sound, and raised DVP, it's not just pericardial effusion, it's already tamponade. In diagnosis of pericardial effusion, mainly we have been taught by since medical student, the ECG changes with electrical alternance because of the swinging of the heart, low voltage because of compression of the heart, and commonly sinus tachycardia that we see in most of the patients with advanced lung cancer. Echo is the gold standard. It's very useful for us to see and assess the size of effusion, the location, and also the hemodynamic effect to the heart. Is it compressed, the RV involved, atrial compressed, and so on. Other imaging like chest X-ray can show us the water bottle sign. A CT scan, MRI is not dynamic as echo, but it does tell us information about how much fluid, is there any loculated or septal effusion happen in pericardial effusion. Initial management in advanced lung cancer with pericardial effusion, we have to consider patient prognosis, when to intervene or not, the availability of local expertise, either we can intervene or not, and also the cardiovascular status of the patient, the medical status of the patient. Is it fit for the intervention or not? And that's why most of the stable patient without evidence of tamponade, we can carefully monitor this patient with serial echo that we can see the progress, and also avoidance of volume depletion. When we intervene, this type of patient, we can intervene when they are symptomatic, and echo demonstrate collapsed chamber. It can be done by drainage, either percutaneous, which is pericardiocentesis, our open drainage surgically with a subxiphoid or anterolateral thoracotomy approach, which need to be done under general anesthesia. VETS by doing a pericardial window. We have to bear in mind, if you do VETS, you need lung isolation. Can it be done without lung isolation? Yes, can, but a bit difficult. The best, if you can isolate the lung, we can see the pericardium properly and put a window. Airway obstruction is another presentation in advanced lung cancer. If they have worsening symptom like dyspnea, stridor, hemoptysis, this group of patients warrant prompt biopsy, prompt bronchoscopy for further evaluation. It can be intraluminal, intramural, and also extramural. And this palliative bronchoscopy intervention can work as a mechanical barrier with a short-term ETT. Can put airway statement placement. With this bronchoscopy intervention, tumor debulking can be done, and also balloon dilatation. Balloon dilatation works best with stenosis involving small area in conjunction with stent placement. All these endobrachial therapies allow rapid symptomatic relief, often well tolerated with minimal toxicities to the patient. It varies. All this endoluminal obstruction can be palliated either using electrocautery, brachytherapy, laser therapy, photodynamic therapy, and also stenting. Combination therapy is advocated if a patient have extraluminal and also infiltrating lesion at the same time. Brachytherapy, endobronchial brachytherapy, if compared to EBRT or external beam radiotherapy, is allow higher irradiation dose to the tumor. It less irradiation to the surrounding tissue. Yet, EBRT is preferred for first-line therapy in this group of patients. Brachytherapy is optimally for previous irradiated symptomatic patient with a central obstruction. However, brachytherapy is not suitable for large tumor and also adjacent lymph node metastasis. It has a high risk of late toxicities, for example, massive hemoptysis, tracheoesophageal fistula, brachial stenosis, and also bronchospasm. Laser therapy utilized widely for intraluminal tubal ablation in a tracheobronchial lesion, which is more proximal, better than photodynamic therapy. It's reported have 50 to 90% immediate relief, not for tumors located at lobar or segmental bronchi, which is more distally. But laser therapy actually have a few documented complications. For example, massive bleeding up to 6%, perforation 3%, and procedural mortality rate of 2%, which is none in a photodynamic therapy. Photodynamic therapy show some good improvement in listening and pulmonary function. It has a minimal toxicities, safely combined with other therapy, for example, EBRT. And it does reported have provide endoluminal obstruction decrease from 86 to 18% and have a significant improvement in FVC and FEV1. Otherwise, both photodynamic and laser therapy have a similar efficacy in relieving intraluminal obstruction and also improve symptom. However, it's require repeat session. But photodynamic therapy allow for longer time treatment failure and more limited toxicity profile compared to laser. How about airway stent? Airway stent can be used for extrinsic and intrinsic compression. It can be used in conjunction with other technique, either laser debridement or balloon dilatation. And the true contraindication for airway stent is the obstruction due to external compression of the vessel. It is a high risk of erosion. And of course, when you have erosion, you get hemorrhage. Uncontrolled hemorrhage is going to be death to the patient. Tracheoesophageal fistula is another complication that's very difficult for us to manage. It has a significant burden to the patient. It causes aspiration, pneumonitis, patient unable to tolerate orally, in marked reduced survival up to 7 weeks. An aggressive intervention for this patient, either surgical repair, surgical resection, should be avoided. Although there are reports of stenting both trachea and esophagus, however, it's only yield modest benefit in very limited trial. Hemoptysis is another troublesome presentation. And as we know that most advanced lung cancer, they are post-surgical candidate. And this group of patients, they benefit less aggressive intervention. As a bronchial angiography, bronchial artery embolization may control the hemoptysis. Other than that, is a therapeutic bronchoscopy, which the area of bleeding can be visualized directly. Electrocautery, the laser coagulation can be used with a reported response rate of 60 to 100%. And other than that, therapeutic bronchoscopy can do some sort of temporizing measure with a balloon tamponade and also infusion of vasoactive agent like epinephrine. How about advanced non-small lung cancer metastasis to the other organ, for example, to the brain, adrenal, liver, spine, and bone? This group of patients have decreased overall survival. They have high symptom burden and significantly worsen quality of life and symptom score. And the palliation achieved mainly via medical management, and is often directed towards a specific symptom to the patient. For example, for brain, the systemic steroid, anti-epileptic, whole brain radiation therapy, stereotactic radiotherapy, and also neurosurgical resection can be an option to the patient. For liver and adrenal, surgery, stereotactic body radiotherapy, palliative EBRT, RFA, or systemic therapy can be offered. Like bone and spinal with pain, they can offer systemic steroid. They can do surgery followed by external beam radiation therapy, or maybe just radiotherapy if the patient with limited life expectancies, if not as surgical candidates. When we talk about palliative systemic therapy, the principle and as an overview for the systemic therapy in palliative, the early palliative care initiation with chemotherapy, either single agent or chemotherapy, does improve survival for several months compared to supportive care alone. So we have some benefit. And newer third generation cytotoxic agent increase median overall survival and also progress free survival. And by combined with targeted therapy, it improves outcome. However, there's no consensus use of cytotoxic chemotherapy among elderly and also among patients with a limited performance because it's associated with a patient morbidity. In patients with a refractory and progressive non-small cell lung cancer in advance, the second line agent does improve quality of life and also overall survival. How about palliative EBRT? We see the function just now from a previous slide. Mainly in palliation, using EBRT is attempt to symptomatically improve localized symptom from the disease. It's not for cancer cure, and 58% of palliation management involve radiation. And palliative external thoracic beam radiotherapy is well tolerated by most of the patient. It does achieve a symptomatic response rate to the patient, up to 91% patient with hemoptysis, 6 to 85% patient with chest pain, 50 to 60% with cough, 40 to 60% with dyspnea. And most of the radiation that being given to the patient for the palliative purpose is a lower dose. So no single regimen is optimal for symptomatic palliation. And the symptomatic response did not differ based on number of fraction administered. Lastly, take-home message in advanced stage 4 lung cancer, the aim of palliative management is to improve quality of life. And the involvement of a multidisciplinary team is important to give and to provide the best for the patient. And any intervention to the patient have to weigh at the risk versus benefit. Thank you. Back to you, Punnarek.
Okay, thank you, Adli.
Yeah.
And yes, yes, it was quite a extensive review. And I know that most of us have encountered, facing the problem with the palliative management for these patients, especially the mammalian perfusion, which for me it is the most common situation that they face. And according to your review, do you have any comment on the new treatment like the perfusion of the thermal chemotherapy into the pleural space?
There are report on chemotherapy into the pleural space. The common they put as bleomycin, but looking at the antineoplastic versus the PLEURODESIS, the outcome still the same. I mean, in terms of outcome, that's why the ample and time mentioned about what we call that. Although because most of these patients, their lifespan is not long, 6 months, 1 year, and then if their survival is more than 6 months, they need another intervention, another PLEURODESIS and so on. Yeah.
Mm-hmm. Okay, we have a question from the attendees, and those who have any question can type your question, and Dr. Adli will answer this. I think the question is about the indwelling pleural catheter.
Yes, how long can we keep an IPC catheter in situ for MPE? I have worked with one consultant that put IPC for 3 months, which is I'm not comfortable with, because I think the safest, of course, when it's not the principle of removing the drain, when it doesn't serve its purpose. If it's not drained anymore, then we can remove. If there's any evidence of infection, we should remove. If it's any evidence that it's not working anymore, it should be removed. If you think this is how long, I would say normal subcutaneous tunnel catheter, it can be placed up to 6 weeks. Can be put longer? I think you have to be carefully monitored. If there's any evidence of infection, you need to be removed. If it's less than 6 weeks, but you have any evidence to suggest that patient have infection or any dysfunction for the catheter, it need to be removed. If you go and read the we call vendor or company suggestion. You will see that most of the subcutaneous catheter they suggest is good and goes up to 6 weeks. Can go more actually. I know patients some 2-3 months, something like that. Second question, having ongoing infection will hinder the oncologist from providing palliative chemo to otherwise a fit patient. What is the recommendation in the management of empyema thoracic inpatient with malignant pleural disease, effusion without lung expansion after drainage? Thank you, Nara. This is very difficult question, very difficult situation, because I think we have to see patient by patient. If you are talking about giving a palliative chemo, the first question we have to consider is the patient is fit or not for the chemo. Element of infection ongoing to the patient, so patient is not for chemo. If patient is symptomatically compromised because of the effusion, if you can drain it as much as possible, then we drain it. The next question, if the lung expansion is not expand after the drainage, how we want to intervene? So is the palliative chemo going to work on him? I doubt it. I think most of these patients need to sit down and discuss with our oncologists and pulmonologists to give the best for the patient.
Okay, before we move to the third question from Dr. Kathian, I would like to ask your comment on how about the internal shunt? Putting the catheter to drain the pleural fluid to the peritoneal.
Yeah, I read about it, but I didn't mention in my presentation.
Yeah.
I have no experience doing it, but it did mention in certain report how the what we call pleural peritoneal drainage.
Yes.
I think eventually, if we have to go basis in patient by patient. If you want to do pleural peritoneal drainage, is going to be a proper surgical intervention. Unless you have other more minimal invasive intervention that we can offer to the patient, it does help. You have the setting, why not? To improve the patient symptom. Prof. Agustian, I think.
Yes, yes.
What is your preferred method to drain pericardial effusion in your practice? What is your rate of recurrence and how do you manage it? Pericardial effusion, the best if patient can tolerate single lung, it's going to be a VETS pericardial window. Especially in recurrence pericardial effusion, if his patient can tolerate GA and cannot tolerate what we call that single lung ventilation, I still can offer anterolateral thoracotomy that I do. Unless patient is purely not suitable for GA, then we can consider pericardocentesis. The problem with pericardial effusion in malignant lung cancer is keep coming. So if you just drain with pericardocentesis, it will come again. So the best still a pericardial window, proper drainage to the pleura, and open drainage. But yet recurrence do happen. I got one patient recently with breast CA, pleural effusion, pericardial effusion. The cardiologist a bit hesitant to drain. They say patient is not in tamponade, but the oncologist referred to me for pericardial window. But of course, he's not fit for surgery. The albumin only 23, and patient is breathless on sitting position. So I talk again to the reason why oncologists want to drain the pericardial effusion, because they need to start the chemotherapy. With the pericardial effusion in place, although it's not tamponade, they need to drain it. So I think the best for the patient, of course, pericardocentesis. I think for the rate of recurrence, most of the patient that I see in my patient, the recurrence rate is a bit high. Most of the time it's high. We put pericardocentesis, drain out, 2-3 months, they come back again with the same presentation. Yeah.
Okay, I have one question. Because we are now in the era of the immunotherapy, the targeted therapy, which prolong survival of the patient.
Yeah.
Would this affect your strategy of palliative management, such as for malignant pericardial effusion? Would you ever consider doing the more aggressive, like anterior pericardectomy, because the patient is now, live longer?
That's a very good question. Because in Malaysia, all those target therapy is quite expensive actually. I think to decide patient on all this targeted therapy, And if there is need of effusion and drainage, I will sit down with my oncologist and see what is the best for the patient. Sometimes this patient is okay without intervention and is asymptomatic with pericardial, even with a pericardial effusion or pleural effusion. I don't bother to drain it. I think the aim is still a palliative and symptomatic relief for the patient. If it's improved, I know some surgeon a bit reluctant to go in if patient already on all this expensive drug. But of course, we always can sit down again, discuss with our oncologist and see what's the best for the patient.
And because most of the guidelines coming from the Western countries, and would you have any modification for the people in ASEAN?
Yeah, I see. I mean, in our practice, I think same as you, our population with lung cancer is younger than they have. So we try to be aggressive most of the time. I do work with my consultant who still do lobectomy in patient with pleural mets, which I feel not justified, but he has his own argument why he did that. But the reason why, because patient is young, but the patient that I told you just now, it was stage 3A initially on CT scan. They go in, do lobectomy, but at the same time, they see a pleural, which is quite multiple pleural nodule and taken as back as metastasis. So after that, after the lobectomy, patient was subjected for intrapleural hypothermic chemotherapy. So although it's not proven on literature, but there is kind of aggressiveness that when some surgeon and consultant deal with a younger patient. I think, again, if you want to do something aggressive, it's good to discuss with our oncologist and consult with other colleagues elsewhere what is the best for the patient.
Okay. Yes, I think yes, we have, because the dialogue will be a little bit late, so we have plenty of time for
patient. Prof. Agustian, some surgeons do decortication for pleural effusion. What is your opinion? I think if a pleural effusion due to the trapped lung, we should go in and do the decortication, let the lung expand. But again, we have to assess properly whether this patient is fit for GA and so on. And of course, when we talk about decortication, we are talking about fibrin which trap the lung that we need to decort the cortex to release and expand the lung. Right.
Okay. The next one is from Harish. I think the same as I have asked you before, the pericardial window.
Okay. What was the question?
Have you have any experience with peritoneal window?
I have no experience. Myself, I have no experience. But I do read about that. I think it's good if it's helpful to the patient. And again, you need a patient which is fit for general for surgery, put under general anesthesia. And again, if there is any intervention which is minimally invasive to the patient, put a pericardial peritoneal window, which you can offer. Why not? But me myself, I don't have that experience.
Okay, I have one case. It is the case that the patient had pericardial window done from other hospital.
Right.
And come to my hospital because of gut obstruction.
Okay.
Yes, because the small bowel, protrude into that window into the pericardial cavity and cause small bowel obstruction. Because at the time the surgeon did the window, in the operative note, the window is quite small, but at the time I operate, the window is very big. So I think we have to be careful creating this window.
Yeah. I think it's important for us to judge what we want to achieve and what this patient can get benefit from what we are doing. Sometimes we thought aggressiveness can give everything, but most of the time it's not. I think we should be wise in decide on the patient.
I think,
you're still waiting for Dr. Dalong?
Yes, I got the message that he will be ready at 8:45 Singapore time. It's another 10 minutes. Okay.
Anytime you want to talk, Pun.
Yeah. Okay, you said from the literature, the review, the talk, it is same between the talk slowly and the talk, which method you prefer for your patient?
I mean, if patient can go for VETs that we can offer, of course, is talk porridge. But if patient is not, not suitable for GA, then talk slowly will be an option for the patient. I think most of the time when we use talk in our setting, the talk is being administered by surgeon. If it's a bleomycin, antibiotic, it can be done by oncologist or pulmonologist. But when come to us as surgeon, it's always talk that we can offer. I think that's the best. Although when we see the paper looking at the IPC and PLEURODESIS, what we call that, looking the best for the patient. But eventually, if the lung can expand, we can drain the fluid as much as possible. We should try to put talk into the cavity and allow PLEURODESIS properly. Yeah. I think Dr. Lim Chong Hee want to comment in chat.
In chat, yeah.
Yeah. Lim Chong Hee.
For trapped lung, there's one question about in case of trapped lung, which is the best method for massive pleural effusion?
I think in trapped lung, we go by symptom. Patient is asymptomatic in advanced lung cancer, we can leave it alone. If it's special symptomatic, of course, it have to be removed. Either if it's the first time, it should be a proper drainage. But if it's a second time, the lung is trapped, then maybe we have to consider patient for indwelling catheter, which can be placed longer compared to normal chest tube, because we are talking about trapped lung.
I think Dr. Lim Chong Hee would like to comment.
Yeah.
I'm not sure which.
Dr. Lim Chong Hee wants to comment. I think she can type.
I'm not sure. John?
Hi, doctor. We cannot, unless we move him to a panelist.
Could you?
Okay, hold on.
Okay, Dr. Lim Chong Hee, we try to move you from the attendee to panelist to allow you to give comment.
Okay, can you hear me now?
Yeah,
can you hear me?
Yeah.
Can you hear me?
Yes.
Okay, thank you very much for the nice talk. I just like to comment is that if there is pericardial effusion and there is sometimes associated left pleural effusion, so you must consider which side of pericardial window you're going to do. So,
good point.
Yeah, so you must consider a peritoneal window with the pericardium, which you make subxiphoid, and then you got to tout the left side. Because it makes no sense, you make the pericardial window and then the pleural effusion is there. It doesn't drain the pericardial effusion. So you must consider all these factors when you are doing a drainage for pericardial effusion. So the other thing is that I don't see any need in doing VATS because a small anterior thoracotomy, about 3 cm, is as minimally invasive as a VATS. So there's no point in putting double lumen tube for this kind of patient. I mean, that's my idea, you know. You just quickly drain the patient and get out as soon as possible because these patients are not suitable cases for general anesthesia. So it's best that you can shorten the operation, do a quick operation and decide quickly what you're going to do. That is my comment, yeah.
Yeah, I agree with you, Dr. Lim. Thank you.
Yes. The benefit of using VATS for this case is probably you can explore the whole pleural cavity at the same time and get some tissue for because right now you have to send a lot of tissue for the, not only for the pathology, but for the, you know, EGFR, that sort of thing. So with
True.
that, sometimes you get more tissue. But just for palliative, I think I agree that just small entry is adequate.
Yeah.
And I think we have some more questions.
Is it from Jakarta? How about pleurodesis in malignancy pleural effusion? Does that mean that we are talking about malignant pleural effusion, pleurodesis?
Which one?
After Dr. Lim.
Oh, from the chat, right?
Yeah.
I'm not sure.
I think the question is, how about pleurodesis in malignancy pleural effusion? I think we discussed just now that pleural MPE or malignant pleural effusion, we can drain them, we can drain drain the fluid, and then if the lung expand, then we can consider pleurodesis using TALC, unless it's not well expanded or the lung is trapped, then we can consider long-term IPC. Yeah, that's the thing that we discussed just now. Yeah.
There's question from Dr. Sladin regarding the cryosurgery or microwave ablation for palliative to reduce the tumor volume. What's your comment on this?
Hold on.
The last question in
okay.
QA.
How about cryosurgery or microwave ablation as palliative treatment? I don't have experience on this. I think this cryosurgery and microablation, if it's for palliative, you can consider. I don't have the expertise on this. I have no experience at all. But if it's intraluminal and can be controlled, and of course we know what is the complication that may arise from this problem, you can consider. Again, it should be done under controlled environment and with a multidisciplinary decision. Because if you're talking about large primary tumor in advanced lung cancer, are we talking about curative? Of course not. Are we talking about to reduce the symptom? And then of course, we have other options apart from resection or debulking. Yeah.
Okay. I think because Dr. Dalong is not ready yet.
Okay.
And,
I think I saw Prof Agastian is very active tonight. He's testing me, is it?
yeah. Okay.
Yes, Prof. As a side question, most patients with malignant mesothelioma present late. Yes, I agree. How do you palliate them in your practice? Most of these mesothelioma patients, they come with pain. Pleural effusion wise, yes, but draining of the pollution doesn't help them much. It's not easy, of course, to palliate patient with mesothelioma. We do work with a palliative physician in terms of pain management, in terms of other what I call psychological aspect, spiritual and so on, to palliate them. I think in terms of surgery is very limited if they come late. It's very challenging if you have this kind of a patient. Yeah.
Yes, I think first of all we have to very careful talking with other specialties, and he's very advanced or how long he can survive. I think right now, most of the time when it is very late, my first action is only thoracocentesis. Wait and see, and which is probably best for the patient. But if the patient had, although he is coming late, but he has a chance to live longer with those target therapy or something, I think more aggressive approach will be appropriate for this patient.
Yeah. Yeah, I saw
Okay.
Dr.
Yeah.
Is it time? Dr. Tin, can we ask?
Yeah.
Dr. Tin question, yeah. How do you choose pleurodesis agent? Always biomycin? Is there any protocol to combat pain after pleurodesis? I think to choose PLEURODESIS agent, in my center, we as a surgeon, we use TALC first. Bleomycin is not the first one, and it's always bleomycin because we have the, what we call that, preference on TALC, and also the luxury to use that. Is there any protocol to combat pain after PLEURODESIS? Usually, if it's a bedside procedure, especially like bleomycin, we put intrapleural lidocaine, or maybe some anesthetic suggest to us to put long-acting like Markin and so on. That does help to combat the pain after PLEURODESIS. Of course, other systemic analgesic, although many believe that NSAID is a contraindicated, either it's relative or true contraindicated. I think that can be discussed, and because it's a bit controversial. Otherwise, in terms of pain, we always can use opiate to combat the pain after PLEURODESIS. Yeah.
Okay, there is a question about immunotherapy, but I think there's quite a big topic.
Yeah.
Yeah.
I'm not the man to answer that.
Any question? Hepatic effusion, what is that? How do you manage recurrent hepatic effusion? From Nabi.
I think it's very interesting. Hepatic is near the liver. I think it's good to discuss with hepatomegaly surgeon. I mean, are we talking about hepatic around the, is it perihepatic effusion? Are we talking about ascites? I'm not sure, because if you have a perihepatic effusion, if it is just effusion, not infective, I think we don't do anything. But I'm not sure what's this question.
I think the comment from Edmund is very interesting, as I told you. Yeah, because we're now in the era of catheter therapy, immunotherapy, so the oncologists always need more and more tissue. And Edmund said he has been doing more VATS biopsy for known cases, stage 4 lung cancer after chemotherapy, because the medical oncologists would like to get new tissue samples because of possible tumor biomarker mutation, which can alter the chemotherapy regimen. Yes, it's true.
Yeah, that's a good point, Edmund.
Okay, what is Dr. Punnarek asked for your comment on PROREX.
PROREX is like a IPC, right? If I'm not mistaken.
Yes, kind of.
Yeah,
IPC.
I think it's yeah. I don't have experience to use it, but I know it's one of the options that we can use to drain the pleural effusion in malignant pleural effusion. There shouldn't be not a big deal to use a PROREX in patient with a malignant pleural effusion. Yeah. Ronald Atika asked about how about pleurectomy in mesothelioma. I know that Professor Agustin doing this and show us how he does and how he did pleurectomy in mesothelioma. I haven't done any. I mean, it has to be justified. When Prof Agustin talked about pleurectomy in mesothelioma, he mentioned about the outcome and what he want to gain from the resection. Of course, it has to be properly selected if you want to choose patient for pleurectomy in mesothelioma. Yeah.
I think someone would like to comment on cryosurgery and pericardial decompression. I'm not sure. John, can you allow who is the heart and heart? This one from our attendees. Heart and Heart Lung Symposium would like to comment on cryosurgery. John,
Hi, doctor. I already unmute them. They can talk.
Okay.
Hello.
Yes.
Mr. Hart.
Hello, can you hear me?
Yes, yes, we can.
And so I just want the privilege of floor for just a couple of minutes. Number one is thank you very much for the very interesting input you've given. One point I think may be useful is that I think for pretty sick patients, one must write them off from a very light anesthesia and a rapid decompression of the pericardial effusion. In my experience, I've had some of these very sick patients, and they dramatically improve with pericardial drainage. You'll be surprised the good that you can confer to this group of patients. So I think before you write them off or you do the minimum of pericardial, I mean, it's just a pericardial tab, I think you can get a great deal of benefit, you know, with a quick, short anesthesia and a quick surgical intervention. And the hemodynamics improve dramatically. Number two is regarding cryosurgery. I mean, I've been to Fuda Center many times, and they are a great center for doing cryosurgery. And I think there is a place for it. I've seen pretty reasonable palliative results out of it. It's not such a difficult procedure, and they do it with CT scan guided, CT guided kind of intervention, you see. And in some of these cases where the tumor is large, they actually put in some radon seeds, you know, peripheral to the ice ball, so that they are able to reach out to the peripheral sliver of tumor that it's not sort of dealt with by the cryo, you see, because the cryo you can only get up to a certain diameter, and the tumor may be bigger than the ice ball. So they implant these radon seeds peripheral to the ice ball so that they can get the radiation effect on the peripheral sliver of tumor tissue. So I think it is something I feel that Malaysians and the region should really consider, because it's unfortunate that, you know, I want to develop it, but the things that I had a lot of obstacles. But for you younger generations of surgeons, I think you should really consider it as one of the palliative options, and actually they have demonstrated pretty reasonable results. That's all I have to say. Thank you.
Thank you.
Thank you very much. Yeah.
You know who's speaking just now? It's all right.
Okay.
I'm YC Lim.
Oh, it's the way.
Thank you. Okay, is there any question?
Dr. Dalong still not ready, eh?
Yeah. I think we have to move him to other session next time.
Okay.
Yeah.
There's a Dr. Nara. What kind of patient malignant pleural effusion that you think is suitable to be selected for hyperthermic intrathoracic chemotherapy? I have no experience on this. I work in a center where they do this hyperthermic intrathoracic chemotherapy. But the group of patients that they use and do in hyperthermic intrathoracic chemotherapy is the patient with advanced lung cancer, which is resectable, but with pleural involvement. So they resect and they put patient on this, what we call that, this procedure. It's a questionable. During my time, they're collecting data. I want to provide the result, but till date, I don't see the result yet. But for the malignant pleural effusion, I'm not sure how good, because we don't have a hard data to suggest that this procedure will help. Yeah.
Okay, thank you. I think we have a very interactive session this time.
I'm alone.
It's quite good, you know. And actually, you should provide more time for Q&A. Yes. Okay, thank you very much, Dr. Adli and all the attendees. I think we have a very fruitful session tonight.
Thank you. Thank you very much, Dr. Poon.
Yes, we would like to apologize for the absence of Dr. Dalong, and we'll try to get him to give a lecture on that topic later on. Okay, thank you very much, everybody. Thank you.
Thank you.